Hello and welcome to today's Community Engagement webinar. My name is Deborah Volleson and I am the Director of Community Engagement here at Kaweah Health. And like always, sitting next to me in the chair is our CEO, Gary Herbst. And Gary, today we're going to talk about a few things, some questions that we've been receiving in the community, either at one of our advisory councils or just from various community members. These are things that range from the financials of the hospital all the way to our new industrial park clinic. So welcome, Gary.
I don't know how many of these we've done now, but you think I'd have it down by
Since
now?
2020.
But I'm walking over here to the studio thinking like, now, how do I start this? How do I welcome do I say welcome to the community engagement huddle?
Mm-hmm.
Because every 2 weeks we do the Kaweah Health Employee Huddle, and I open that. I welcome everybody. I forgot that for this one, you welcome everybody.
For this one, it's
that's
all
why I couldn't
me
remember.
those first few seconds.
As
Yeah.
it should be. As it should be. So.
Well, we're
But
very,
yeah, it's great to be here, and
Yeah.
welcome to all
Yeah.
of you for joining us on this Thursday afternoon.
Right, and these are just really to keep people informed of things that are concerning Kaweah Health and topics. They can chat in live, they can send emails. Don't call, but you can message us because it's really important that people get the information from us,
Mhm.
not from the newspaper, not from online social media posts.
Yes.
And so this is just what we're doing, what the point of these webinars
Right, yeah,
is. And I'm all
yes.
miscombobulated. I don't know.
That is a
I
word,
can't even
huh?
say words today.
Yeah.
Okay, so let's go ahead and start. I know you have been talking about how busy the hospital is, so tell us exactly how busy we are.
Yeah, it's been really pretty unpredictable, pretty volatile actually. Just a few weeks ago, we were consistently, running 90+% in the acute medical center across all of our adult units. But then last week I saw it dip down into the 70%. Today it's 7 o'clock this morning, so every morning it comes out. Every morning at 7, and then again at 7 p.m. or 9 p.m. But so at 7 o'clock this morning, we were right at about 80% occupancy in the adult areas of the acute medical center. Interestingly, where we're feeling the most pressure is in the medical surgical side, so not so much in the intensive care or critical care side. I think I've mentioned to you in the past, we have 2 ICUs, a 21-bed medical ICU and a 20-bed cardiovascular ICU. So 41 total beds across those 2 units. And as of 7 o'clock this morning, 25 of those 41 beds were unoccupied. So that's a good thing for the community. We have fewer patients in critical care. And then we also have 2 intermediate critical care units. So on 3 West, we have 30 ICCU beds, and then in the Asequia Wing Tower, 5 Tower, the 5th floor, we have a 24-bed unit. So between the 2, we have 54 beds, and also 25 of those 54 beds were available for an admission for occupancy. Where we feel definitely much tighter is in the medical surgical. So when we talk 2 South, 2 North, 3 South, 3 North, the cardiac unit, 4 Tower, Broderick Pavilion, places like that. We have 237 total adult medical surgical beds in the medical center, and we had 16 of those were unoccupied. We only had 2 patients that were down in the emergency department that a determination had been made that they needed to be admitted, and we were just waiting to move them upstairs. So it wasn't that we didn't have beds for them, and certainly by now they've gone up. I don't generally report on the pediatric side, so I thought I would. So we have a 12-bed dedicated pediatric unit, and as of 7 o'clock this morning, we had 5 pediatric patients that were in that on that unit. And then our beautiful state-of-the-art 23-bed neonatal intensive care unit, which is on the 6th floor of the Asequia Wing. We had 17 of those 23 beds were occupied. So number of births has been really up and down over this year as well. It's now up, which is why our NICU occupancy is up. They do definitely go hand in hand. But we have a phenomenal team of neonatologists and nurses that take care of some of our tiniest patients. And I was talking to Melissa Filipponi just this week. Melissa oversees our mother baby services, and interestingly, the guidelines for us accepting neonates, literally we have neonates that are born at 23, 24, 25 weeks. Melissa said that literally the baby could fit in one hand. And we take care of them, and we have miraculous stories. They spend some time with us, many times several months, but then discharge and they go home to mom and dad. And in fact, Dr. Tadaldi, I got a chance, he's one of our hospitalists here at Kaweah. His son was born here at 29 weeks and spent some time in our NICU, but I got to meet his son. He's just a rambunctious little boy running around. You would have never had any idea that he was born that early. So just kudos to that team.
Yeah, so we're going to talk about L&D and our Valley Children's partnership in just a minute, but I want to go back to the census percentage, because
Yes.
you always talk about a sweet spot, but it sounds like it just depends on where the patients are, because I think you've said 80% is like a sweet spot.
Yeah, it used to be 75 to 80% occupancy. Gives you some wiggle room for being able to flex up or down if you have an unanticipated surge of patients. You generally are well staffed at that level, and it's just like an equilibrium that allows you to provide some of the highest quality, safest care. Usually it's very efficient, cost effective. That's always kind of been the benchmark for hospitals as far as I can remember. So 80% occupancy, I would definitely say would be that sweet spot. But as you just commented on, that there's an assumption that it's kind of like 80% across the entire hospital. 80% occupied in critical care, 80% in med surg and the pediatric areas, and that hasn't been. It's a very disproportionate. I mean, yeah, the average is 80%, but it's 50% in critical care and 95% in med surg. So,
and the majority of the time, those ED patients that are waiting to be admitted would be going to a med surg bed.
Generally speaking, although I worry that this is a bit of the calm before the storm. So we haven't obviously entered into the full respiratory season yet. Flu, COVID, RSV, just respiratory conditions in general. Unfortunately, we have a high prevalence of congestive heart failure and COPD and asthma among our community, and so the winter months tend to exacerbate that. And so we're anticipating it's going to be a relatively moderate respiratory season. That's what the CDC is saying. Oftentimes we track what's going down in the southern hemisphere, Australia, New Zealand, they've already come out of their winter, and I believe that they had a relatively moderate. We were bracing for what might be a very intense respiratory season, but all indications are it should be fairly moderate. We are ramping up, particularly the ED. The ED continues to be really unexpectedly busy for this time of year, so we're consistently seeing 260 to 300 visits a day, which is amazing. We were just meeting before I came down here talking about the ED and surge planning, and so we have 22 nurse travelers right now in the ED, and we have more coming on. We currently have 44, I think it is, open RN positions in the emergency department. So those are, employed nurses. So we're short there, but it doesn't mean we're understaffed, because we're making up for that shortfall with almost 30 travelers after the new ones arrive, overtime, extra shift bonuses, and so we're not running short staff. And the plan is to keep all 73 beds open for close to 20 hours a day, 7 days a week, so that we can move patients quickly through the ED, that your stay in the waiting room would be very short. Certainly patients coming in that are level 1, level 2. Level 1's trauma, level 2 is still very sick, injury or illness, and so we get those patients back as quickly as possible. The 3, 4s, and 5s, though, we still do our medical screenings and treat, and but you've got to triage. Obviously the sickest, the most injured patients, you have to address their needs first.
Yeah. But regarding those 40-some open positions, I had no idea until we started the Emergency Department Advisory Council that their orientation is so different than what I'm used
Than
to.
a medical surgical?
One-day
Yeah.
orientation.
Oh, yes.
An employee comes
12
on.
weeks, yeah.
It is a long orientation for an emergency department nurse.
Yeah.
So.
Well, the emergency department, the ICU, surgery, those are definitely the most intense areas. And I always just so appreciative and amazed by our nurses that go into the emergency department, because it is very, very busy, very hectic. You see all kinds of pathology coming through, and it just takes a special person. But we have so many people that they thrive in that environment. They really, that's where they get their joy, is just the variety, the uncertainty of what you're going to see. Great camaraderie. It really is a very tight-knit family in the ED, and they support one another, and but just some remarkable people there.
Yeah. All right, so back to the NICU, and we've been asked about the Valley Children's partnership, because a lot of people were confused about what that was, and then when it was announced that Valley Children's was going out on 99, there was a lot of talk about, they're bringing a Valley Children's hospital to our area, and so people didn't understand. We've had a partnership with Valley Children's for several years.
I would say we've had a partnership with them for decades, but more of an informal partnership. So we have always worked very closely with Valley Children's Hospital. They are our primary children's hospital, that when we've not been able to take care of a child that comes through the emergency department, or however they come to us, we always have tried to take care of as many children here as we can in our community, but we recognize our limitations and skills and so forth. And so Valley Children's has always been kind of our go-to partner. So that relationship's always existed. But back on February 1st, 2017, so a little more than 6 years ago, we actually entered into a formal relationship with Valley Children's. We entered into what's called a professional services agreement, and it actually is with Valley Children's Medical Group. So there's Valley Children's Hospital, and then there's the Valley Children's Medical Group, who is the medical group that primarily provides all the care in Valley Children's. But you may have remembered me saying this before, while doctors across most of the country are employees of the hospital, California is about a half a dozen or so states that prohibit hospitals from employing doctors. It's called the corporate practice of medicine. So the Valley Children's Medical Group is actually a separate corporation, a separate entity, but they all have privileges to work and take care of patients at Valley Children's Hospital. So our contract and that formal relationship is with that Valley Children's Medical Group. And so through that agreement, Valley Children's Medical Group provides us pediatric hospitalists. So these are pediatricians who are trained to essentially provide hospital care. So they tend not to have, an outpatient practice, a pediatric office or clinic, but they work pretty much exclusively in the hospital, taking care of hospitalized pediatric patients. So Dr. Randolph is Julianne Randolph is the medical director of the Pediatric Hospitalist Program. She happens to also be the Vice Chief of Staff. So in a couple of years, she will become the Kaweah Health Chief of Staff. But she is employed by Valley Children's Medical Group, and they've placed her in our community and at our hospital to be the medical director of our Pediatric Hospitalist Program. So those Valley Children's pediatricians, they cover that 12-bed pediatric unit. They work in the emergency department with our emergency medicine physicians when we have pediatric patients come in. They respond to the nursery, they go to labor and delivery. So they really work throughout the acute medical center where we have pediatric patients. And then in addition to that, that same contract with Valley Children's Medical Group, they provide neonatologists. So board certified neonatologists, they're part of that Valley Children's Medical Group, but they staff our 23-bed neonatal intensive care unit. So if you have a child that's in the NICU or on the PEDS unit, those doctors that are taking care of your child are Valley Children's physicians. So they have all of the benefits, the resources of being part of the Valley Children's network. Obviously, they're credentialed and vetted by Valley Children, so they meet their quality of care to be a part of the Valley Children's healthcare system. They also they apply for privileges through our medical staff to be able to work here too. So they have to be credentialed by both Valley Children's as well as Kaweah Health. So that formal relationship is in place. There's still Kaweah's beds. They're on our license. Those are our staff, our nurses, our CNAs or LVNs, all the people that are taking care of those children are Kaweah Health employees who, in partnership with those Valley Children's physicians, are providing that care. And it's been a wonderful relationship, and I think it's done a couple things. Number one, it's allowed us to care for more children of our community, are able to stay here in Visalia and receive outstanding care from Valley Children's physicians, whether again it's in the NICU or the PEDS unit or the ED. And those physicians, if they need to reach out to their colleagues up in Madera for support, guidance, advice, they can do that. But they also can expedite a transfer too. Because they're part of the Valley Children's Network and they have all their colleagues up in Madera, they're able to really be able to expedite quickly in the event we need to transfer that patient to a higher level of care. So it's been a great partnership. We really enjoy working with Todd Suntrapak, the CEO at Valley Children's. I know Todd very well. Jane Wilson, Michael Gallagher, just a lot of great folks there up at Children's. But what preceded that contract is we actually had an earlier agreement that's still in place with that same Valley Children's Medical Group that provides maternal fetal medicine physicians to us. So you may remember them as perinatologists. So you got neonatologists, you have perinatologists. And so those are specialty trained OBGYN physicians that are, they have fellowships in perinatology, now called maternal fetal medicine, and they work with moms who have high-risk births. So before we entered into that relationship with Valley Children's, most of our moms that were going to have a high-risk birth had to travel to Fresno and receive their prenatal care through one of Fresno's maternal fetal medicine physicians, and then oftentimes would deliver their baby at St. Agnes. So they would have to leave Visalia to have their baby. Now, those Valley Children's maternal fetal medicine physicians live in our community. In fact, their office is over on the corner of Mineral King and Acres, that the northeast corner there next to
Denny's.
Denny's? Yeah. So you'll see the Valley Children's Medical Group sign up on the top of the building. So that's where their offices are, and they see moms on an outpatient basis. But then they also are in the hospital here. So we now deliver those high-risk births, working with local obstetricians. So the mom, the pregnant mom, might have, Dr. Wiseman, Dr. Boken, has an OBGYN with Visalia OBGYN, and that's who they're getting their prenatal care. But that obstetrician is also working with the Valley Children's maternal fetal medicine physician to consult and provide support and be present during the delivery. And so again, just wonderful to be able to provide that really high caliber, specialized service right here in our local community.
So if a woman moves to the area that does not have an OBGYN, goes into labor, is it like a local pool of like somebody from Visalia OBGYN who's on call, or is it a Valley Children's Hospital
Yeah,
that would
actually,
deliver?
that's a great question. So a couple of years ago, Kaweah actually developed a formal, what's called a laborist program. So generally speaking, most every expectant mom has an OBGYN, either through a private practice OBGYN or through one of the federally qualified health centers like Family Healthcare Network or Altura, United Healthcare. We have a very, very robust obstetrical practice in our Exeter clinic. Dr. Sabagal, Dr. Kadimi deliver hundreds and hundreds of babies every year. So pretty much every mom's able to get connected. But you're right, if an expectant mom's traveling through Visalia and goes into labor and comes to Kaweah, then we have on-call and generally speaking in-house OBGYNs, these laborists that are ready to deliver that baby.
Wow.
Yeah, so we really, the whole mother-baby, labor and delivery, maternal child care, our relationship with Valley Children's and has really developed a top-notch program. And we deliver almost 5,000 babies a year. So it's really important, having that state-of-the-art NICU, having the maternal fetal medicine physicians. Valley Children's has been a great partner. You spoke of the land out at 99. Mm-hmm. So Caldwell and 99, which is called the Sequoia Gateway Project. Valley Children's bought 6 acres of land. Kaweah Health owns 7 acres of land out there. Despite the rumors that were going around, Valley Children's had and has no intention of building a hospital there. What they want to do is build a dedicated specialty pediatric clinic. Mm-hmm. So that clinic I referenced on Acres and Mineral King, they lease that space. They eventually would like to move out of there into their own owned clinic on that 6 acres and to expand the available pediatric care in this region. Mm-hmm. They don't have any interest in going into primary pediatric care. They kind of leave that to community pediatricians, but they definitely want to be able to continue to provide that specialty care. And then ideally, and we're in frequent conversation with Valley Children's, is to do something in concert with them. That potentially Kaweah could develop an adult primary and specialty care clinic there in concert with Valley Children's pediatric clinic, kind of similar to what Valley Children's and Adventist Health did in Fowler. Mm-hmm. So if you're driving along 99 there on the east side, you see that clinic there. That's a joint venture. with Adventist Health and Valley Children's, and so we would look forward to doing something like that on that Caldwell property.
All right, great, thank you. All right, so let's talk about some of our other clinics. Industrial Park Clinic, did it open today?
It did.
Yeah.
Yes. I was holding my breath when yes, so today is the first day. I confirm that it is in fact open. I know we definitely had some delays. I didn't think that the supply chain, disruption that we've all been experiencing worldwide over the last several years, it did impact us in terms of acquiring heating, HVAC equipment. So I don't know if we were stuck out on a boat in the ocean, but there were some delays there, and so finally it's open. So we're serving that industrial area in that ever-growing industrial park out there. Occupational health, very excited about that for all those employers out there to be able to do pre-employment screenings and workers' comp evaluations, and so exciting to have that open.
Yeah, and they're excited. I've been talking about it out there for a couple of years, and if you're not used to going out into the industrial park, it's amazing.
Oh yeah, it's
It
enormous.
is almost all filled up. We've got
Yes.
big organizations that have come in, and Ryan kept saying, Ryan Gates, our vice president of population health, chief of population health, he kept saying it's going to be a soft opening because
Right.
we don't really know all of the services that they're going to be needing, but very exciting, and it is booming out
Yes.
of the industrial park.
It is.
So we're very excited about that. Okay, so then we have a new doctor in town at our cardiovascular clinic.
Yes. So we're excited to announce that on October 16th, Dr. Michael McLean formally arrived here in Visalia. He is a cardiothoracic surgeon, so a cardiac surgeon. He is part of the Stanford Health system, part of their cardiac surgery medical group. So he is on the faculty of Stanford Health, but he also is now part of our community, and we are very excited to have him. He's already done a number of open heart surgery cases, so he didn't waste any time into diving right in. He's located with Dr. Mayer over on Kaweah, kind of set back a little bit to the north there. So it's facing Kaweah. I think it's where the old Suncrest Bank was. So they lease space there, and you'll see the Kaweah Health Cardiothoracic Medical Group sign up there. So that's where Dr. McLean and Dr. Mayer work. So a little bit about him. So he attended medical school at Wake Forest University in North Carolina, and he did his residency in general surgery at State University of New York's Buffalo School of Medicine and Biomedical Sciences. He then completed his cardiothoracic surgery fellowship at the University of Southern California, so USC. His special areas of training include minimally invasive cardiac valve surgery, esophageal surgery, minimally invasive thoracic surgery, endovascular aortic surgery, heart-lung transplantation, which we do not do heart transplants here, but Dr. McLean has done them prior to arriving here, and congenital heart surgery as well. So we are very excited to have Dr. McLean here. So Dr. McLean is the first of 3 Stanford Health cardiothoracic surgeons that we will ultimately place here in Visalia, all part of the Stanford Health system, would all be faculty there. But sadly, we recognize that eventually Dr. Mayer is going to ride off into the sunset. He's been pretty clear with me that he's going to retire from full-time practice in just a few months here. He does want to still keep his hand in cardiac surgery, and we are actively working with Stanford to recruit 2 additional full-time cardiothoracic surgeons that will then join Dr. McLean, and we will have 3 cardiothoracic surgeons in our community.
That is a busy place.
It is.
Our cardiac.
Well, we have 22 cardiologists on staff, and it is a very, very busy service. We do a lot of interventional cardiology, so the placement of stents, pacemakers, other cardiovascular devices. We are doing TAVR procedures, which is transaortic TAVR.
Valve replacement.
Valve replacement. Thank you, Maria. Yes, transcatheter valve replacement. So a number of our structural heart physicians. So Dr. Ankar Gupta, Dr. Singla, Dr. Rafi, all doing TAVR procedures supported by cardiac surgeons, and I think Dr. Sharma does them as well. And then most recently we started performing the Watchman procedure. So for those of you that might suffer from atrial fibrillation, the Watchman device is placed in that atrium to prevent any blood clots that could form in that pocket from getting out of your heart and moving into places that could cause a stroke or other adverse events. So we've done a number of Watchman procedures. I know they're also looking at PFO closures and mitral clip procedures, and so it's fascinating and inspiring to see just our cardiovascular program continue to grow, and just great people coming on board.
Well,
too.
it's amazing. We were just in that community meeting at the foundation board meeting last week when that nurse was there talking about the PICU lines.
Yes.
That they put in that have to land right over the heart, and
yes,
it's just amazing
I think
work.
we had a few members of the foundation that were swooning a bit when the PIC
when she
nurse,
held it up. And,
so she held up the needle so Kelsey over here is about ready to faint. The needle had to be about 6 inches long, and and this is where they go in through your arm. They call it a midline peripheral placement, where they go in with that needle and snake that catheter
all the way up, and has to land at the correct spot.
Well, and
over
they're
your
doing
heart.
ultrasound guided too, so they're not guessing; they're watching where it's going. But it's just amazing.
So I'll share this. A community member had just emailed me, and he had a widowmaker heart attack.
Ooh.
Just a few weeks ago, and he said the care and the Kaweah ED and Dr. Verma saved his life.
Wow.
And the surgical team.
Wonderful.
I thought that was
Wonderful. Yes.
Yeah. Well, welcome, Dr. McLean.
Yes.
We're excited.
Yes, we are.
Very excited. Okay, so another clinic. This question came in. Will Kaweah ever consider having a 24-hour urgent care?
We have considered it, and probably will continue to consider it. But every time we do consider it, the conclusion is it just is not viable. Even staying open till 9 o'clock, the demand falls off pretty dramatically as we get into the later hours. And so if we were open 24 hours a day, we'd have very little usage in the wee hours of the morning. And so to keep it open, to staff it without the volume to support it, it just financially is just not viable to maintain that. So we'll continue, if we saw things start to change, then certainly we'll remain open-minded to it, but it just hasn't penciled out in the past.
Okay. And I just want to confirm this because this question came in as well. So are our urgent cares still walk-in clinics?
Absolutely.
Okay.
Yeah, so you can, so we have urgent care centers on Court Street and on Demery, and you can walk into them at any hours that they're open. So you can physically walk in. Or you can go on to the Kaweah Health website, kaweahhealth.org, and you can actually you can schedule a walk-in visit. So we call that the virtual waiting room. So you can physically walk in without an appointment and go up to the front desk and tell them your chief complaint, and then you'll wait physically in the waiting room until you're called back. Or you can go online without an appointment and see what the wait time might be. And so you can put your name in and schedule that walk-in, but you can wait at home until that time. But then you can just walk in. And I know that sounds like, well, then I have an appointment. Yes, but you made it immediately. It's not like you scheduled something out. You truly are a walk-in, but it's the convenience of being able to, you could wait in your car, but you could also wait at home rather than waiting in the physical waiting room. And we've done surveys to see if that is something people like, and the feedback's been very positive. People like that ability to wait virtually. Yeah.
So don't be deterred when you see appointments or click here for an appointment. You can still walk in.
Yes, absolutely.
Okay. All right. So our September financials.
Yes. So brought them with me. So they're fairly hot off the press. So we continue on our journey to financial recovery, and it is going in the right direction. We still have a long ways to go because the hole that was dug was pretty deep over 3 years. So it'll take some time to ideally get back where we were and then get back really on a path to prosperity again. So we did actually incur a very small operating loss for the month of September. So $150,000 operating loss, which I would call break even, essentially. Even though if that was our own money, that'd be enormous. But we brought in $68 million in revenue in the month of September. And so, to have $150,000 loss on $68 million of revenue is actually is a bit of a victory, so to speak. So to put that into context, so last September, so September of 2022, we lost $12 million, one of the biggest single losses in Kaweah Health's history. That month of September 22, we spent $7.1 million in contract labor, and we were experiencing still a lot of the post-pandemic hesitancy to come to the hospital, people afraid, putting things off. Our revenues were only $61 million for the month, so $7 million less than what we generated this September of 2023. But we literally experienced, if you think a $12 million operating loss last September down to a $150,000 loss this September, that's a $12 million year-over-year improvement. So we're elated by that. Not only was our revenue up, that $7 million, but our contract labor, we spent less than $2 million for the month of September 23 compared to $7.1 million for September of 22. So we also, going into this year, we knew it was still going to be a tough year. We're not going to be completely independent of contract labor. Unfortunately, we're having to actually add more than what we were anticipating just to support the emergency department and just the number of openings we have there right now. So we had actually budgeted to have a $3.8 million operating loss for this September. So again, to only have a $150,000 loss, we significantly outperformed our budget and our expectations. Now, that also does not include a roughly $19 million receivable that we have. We haven't booked it yet, but we did budget for it. And I think I've probably talked about this in the past. So the Federal Emergency Management Agency, or FEMA, who normally provides recovery efforts and financial support for disasters, hurricanes, floods, fires, things of that nature. They also, for the first time, are allowing hospitals to submit disaster claims related to COVID. So losses or expenses that hospitals incurred because of COVID. And that might be having to hire more travelers, having to pay extra shift bonuses, having to buy medications like remdesivir and bamlanivimab and all the things that were used throughout COVID that were essentially unfunded by any of the payers. We can actually now claim requests for reimbursement or recovery of that. So we have this $19 million claim sitting on FEMA's desk that we were losing a little bit of confidence that we were actually going to receive funding under that, particularly when FEMA was hit with a terrible fire in Maui, the floods in California and here in the Central Valley, hurricanes. There's just been a number of disasters that have occurred across the country, and those become the top priorities of FEMA. And so COVID hospital claims kind of fell to the bottom and things kind of seemed to stop. But then Congress passed a continuing resolution, a 45-day CR to keep the government open. And as part of that, they approved $16 billion of additional funding to go to FEMA. And so that has now reignited the efforts around FEMA to process those hospital COVID claims. And we're just one of many, many hospitals that have those claims. So we are increasingly confident that we're going to receive that. And so that will be an immediate $19 million infusion of cash and income. So that we haven't recorded that yet, but that would be certainly well received. I will also tell you that so we're now, our fiscal year starts on July 1. So we're now through the first quarter, July, August, and September. And through that quarter, we do have an operating loss, a cumulative loss of $3.1 million. But that's $7 million better than what we budgeted. We actually budgeted for the first quarter that we'd have a $10 million loss. So only a $3.1 million loss. But also from a bottom line standpoint, when you add in like our investment earnings on our cash and investments, we actually have a positive bottom line of $1.9 million. So it's in the black. And we had budgeted a bottom line loss of $3.8 million. So literally we're $5.7 million ahead of our budget for the first quarter, and we are $31 million better than the first quarter of last year. It obviously didn't come without some heartache and very difficult decisions of laying off staff and closing services, but it was necessary and it is bearing fruit. So we also we are generating positive cash flow. We've seen the number of our days operating expenses, cash on hand, we're at about 83 days at September 30th. At March 31st, we were all the way down to 62. That does not include the $21 million of proceeds that we're supposed to receive under the Distressed Hospital Loan Program. Now that is a loan, it's interest-free, it doesn't need to be repaid, but that's $21 million in cash that we will be receiving. That's not included in that 83 days cash on hand, so that will add probably another 10 days to that number, which actually then will push us above the minimum threshold that we're required to maintain under our bond indenture. So a lot of positive things.
And then we'll get that reserve back that we had to put.
Yeah,
right?
but not for 2 years.
Not
So
for
yeah,
2 years. Okay.
Deborah's referencing that December 31st of 22, we failed to meet our debt service coverage ratio, meaning we didn't generate enough net income, in fact it was net loss, to cover the principal and interest that was coming due. We didn't default on our debt. We've never missed a principal or interest payment, but because we didn't meet that covenant, we had to take $18 million of our unrestricted cash reserves and move it into a trustee account called a bond reserve fund that was sitting there in the event we would default, that the bondholders would at least get paid their principal and interest that was due that year.
Okay. Some people think when you say cash on hand, and I
Right.
know, you're a CPA, you're a numbers guy, but some just non-numbers people hear cash on hand
Right.
and think, oh my gosh, in 66 days they're closing, or 83 days they're closing, 77 days they're closing, because
Right.
that's what they think that
Yeah.
means.
Yeah, no, it's a great question because it's a complex concept. So when we talk about days cash on hand, every business sets money aside. They have their cash reserves, and so actually we're required. We have over $200 million outstanding in tax exempt revenue bonds. So all of our growth in facilities, equipment, generally has always been funded by us, using our profits, our operating revenues less our expenses, to borrow money and to repay it ourselves, the principal and interest, and not look to the voters or the property owners to fund that. As a governmental hospital, as a public hospital, like a school district, we do have the legal ability to go to the voters and ask them to support a general obligation bond. And in that instance, the principal and interest is repaid by property taxes assessed on properties that lie within the 183 square miles that make up the healthcare district. We only have one general obligation bond outstanding right now, and we issued $51 million back in 2004 to help fund the $200 million Kaweah wing. So about a fourth of that tower was funded by the property owners through that GO bond. But so that $200 million in revenue bonds, we go to the market and we sell those as tax-exempt municipal bonds, which a lot of people love holding because the interest income that we pay on those bonds isn't taxable generally for federal or state purposes. And so people like having those. And so we'll go sell those bonds to big mutual funds like Templeton or Franklin or, but those bondholders say, okay, I'll agree to buy your bonds, but you need to be financially solvent. I don't want to take the risk that you're going to default, and so I'm going to monitor your financial performance. In fact, there's a couple key things that I'm going to make certain that you maintain. That debt service coverage ratio is a measure of your profitability. I want to make certain that you're running your hospital well and you're generating a sufficient profit every year to be able to pay the principal and interest. But I also want you to have enough cash in reserves so that if you have a bad year and can't generate that profit, you've got the cash over here to make certain you pay that principal and interest that comes due. And so you entered into what's called a bond indenture. It's a formal document between us and the bondholders. And so that document says that at all times, Kaweah must have enough cash in reserves on hand that it equates to at least 90 days of what your average daily operating expenses are. So far this year, through the first 3 months, it costs $2.3 million a day to run Kaweah. That's our daily operating expenses. So the bondholders say, okay, multiply that by 90, and that's how much cash you need to have in the bank. Now, that is in reserves. So that's where it gets confusing. It's like, you mean you only have enough cash to keep the hospital open for 90 days? The answer would be yes, if I didn't have any other income coming in. If I didn't have any other revenue, but I still have $2.3 million a day in expenses to cover, yes, in 90 days I will run out of cash.
And $68 million came in this month.
Yes, exactly. Now, 68 million also went out this month, right? Because we pretty much broke even.
Right.
So we didn't really have, although we had a net bottom line, because that cash reserves that we have earns interest income. And so this last month, we generated $1.8 million in interest income on that money that's sitting in cash reserves. And so that gave us a bottom line net profit of 1.9 million. We put that amount into the cash reserves. So that's why we've gone from 62 to 83. And our goal is by June 30th to be over 90, because we intend to continue. We just presented our audited financial statements last night to the board. And we looked back 3 years ago, our days cash on hand was 178.
Wow.
Very, very healthy.
Yeah.
An A-rated hospital worthiness. But, we've lost 150 million over the course of the pandemic. And we funded all those losses by dipping into those cash reserves. And so we need to rebuild them. We need to get back to positive cash flow and profitability. But the plan is you don't spend those cash reserves. So I understand, the community thinking, wow, that's, but that's, again, if that's the only thing you had to pay your daily operating expenses, yes, you'd run out of cash and you'd close. But we don't spend that money. We generate through our services, and 99% of our revenue comes from Medicare, Medi-Cal, Blue Cross, Blue Shield. We only receive a little over $1 million a year in property tax support. So that when you get your property tax bill and you look at that top line that says 1%, Kaweah gets a little sliver of that, a little over $1 million, which doesn't even fund us for half a day. If you're spending 2.3 million a day. So as long as we continue to provide outstanding service to our community, to our patients, high quality, safe, satisfying care where people want to come here for their surgeries and deliver their babies, and this is where they come for their care, that generates that revenue that allows us to pay those expenses and not have to touch those cash reserves.
Good explanation.
Okay.
Very good. All right. Well,
that CPA thing comes in handy sometimes.
it really does. Yeah. It really does. All right. So we are done with the questions. So I'm going to let you close this out.
All right. Well, again, thank you. This is my role. You do the opening, I do the closing. Huh? Yeah. Well, it's great being with you here again today. I know we come to you every month, and I want to thank Deborah, and as usual, we've got Daniel and Maria and Kelsey in the production room and doing a great job. Just want to say again, thank you to all of you for your continued support of Kaweah Health. Thank you for your great questions, and never hesitate to pose them. I have community members that email me directly at gherbst@kaweahhealth.org, or you can email Deborah, and she always gets your emails to me. We absolutely want all of you to be the as Deborah kind of said with the opening, we want you to be the most informed members in our community, what Kaweah Health is all about. Our commitment to being a highly transparent organization, that has not waned one bit. And so I continue to be very committed to that promise. And so thank you for tuning in. I hope you all have a wonderful weekend. It feels like fall has finally arrived, and so that's kind of pleasant. So I guess we'll see you next month, right?
Mm-hmm.
All right. Take care.